at least as clinicians we should do is few these things that we follow. So in my talk, I primarily talk on safe scoring and prediction, prep to algorithm, and lower recovery now that is being focused, twist algorithm and twist tool. So what is safe score? Simply shoulder abduction, finger extension, power. So you check this as this basically you are going to check within the first 72 hours, that is within about 3 days. You are going to check how much of shoulder abduction, if you ask them to do, they are able to do, and how much of finger extension they are able to perform. And this can predict the recovery at the end of 3 months, how much it will be. So this prediction model, as per that, it says if the safe score is more than 8, that is almost 4 and 4, if the highly excellent upper limit, they will fully recover. You see that, you know that not much of dexterity issue also will be there. Whereas those between the score of 5 to 7, the prognosis is intermediate. Further evaluation is needed. We're not very sure, but we know that there is some form of recovery. Final moments may be still affected at the end of 3 months. Whereas when it safe score go below 5, then you need further biomarkers to determine how much is the recovery. So safe score less than 5, means the recovery will be relatively poor. So you get a fair idea of upper limb recovery in the first 3 days to know what it is. Now, the safe score is considered as the strongest predictor for bimanual performance, and it also expresses the presence of functional, I mean the function of we won't go there. Next. So if what happens? So next, Kathy Spinner studies were that initially prep algorithm one was that which used safe score 8 as the cutoff. Then they worked around and then they came up with this algorithm where when you do the safe score, if the safe score is more than 5, that is the second category, and if the patient is less than 80 years of age, then they will have excellent recovery. That full recovery happens in all patients with safe score less than more than 5 and age less than 80. On the other hand, if the age is more than that, then again the safe score maybe you have to check the safe score of if it is more than 8. So those who are aged above 80 and has safe score more than 8 will recover. Whereas if it is less than 8 and above 5, will get full recovery. Then you come, the next thing is if it is less than 5, then what? So then they use, what they do is they do a motor evoked potential. Sorry. So motor evoked potential is basically using a TMS machine and pick up the muscle activation just to tell whether the corticospinal tract is intact or not. So you have to check the amplitude and then decide whether it is good or not. And one more tool you need in that 72 hours is usually done by all neurologists. They will put the NIHS score to tell how severe it is. The stroke, the National Institute of Health stroke scale. So you have scores between 0 to 42, and as you can see, 0 is no stroke, sometimes 1 to 4 is minor stroke, 5 to 15 moderate stroke, 16 to 20 moderate to severe, and 21 and above is severe stroke. Now, going back to the algorithm, if the patient scores are lesser, they do a motor evoked potential and it is intact. You are able to get a good amplitude motor evoked potential, then the recovery will be good because the corticospinal tract is intact, so it will recover. But what if it is not intact? Then you check the NIHS score. If the severity is less than 7, there will be limited recovery. If it is more, it will be poor recovery. So this they have described what is excellent and what should be the rehabilitation focus. I encourage you to go back to this paper. Basically, it says about considering compensatory mechanism for poor recovery. We did a few studies to also look at recovery. We are doing 3 more ongoing studies right now. But what we found is, along with safe score and shoulder flexion, it is better. It was PhD of Professor Chitra guided Senthil and co-guided baby. We'll move to the lower limb recovery, that is twist algorithm. So this is a really new one. Again, the same group, the Steeners group, but you can see that they are into primarily two factors. This is to determine whether the patient, can you tell them whether they can walk? And I walk again? The question, that's the question they wanted to answer. And there are two aspects to it. One is the trunk control test score and the hip extension score. Trunk controls test score, it has only 4 items. You just ask them to roll both sides and up coming up to sitting from lying position and sitting balance. Each one is about 25. Your total score is 400. So if they score more than 40 itself, then you're going, the patient will start walking independently by 6 weeks. PCT score more than 40. PCT score less than 40, and then you have to check the hip extensors power, check that and see if it is more than 3, they will start walking by 12 weeks, by 3 months. If it is lesser than that, then they may be dependent walker at the end of 3 months. So this you will give you an idea of what they will reach by the time. Now the what another tool is coming up. It's a derivative of the twist tool. Is the twist twist algorithm. Is the twist tool. Basically, it looks at 3 factors. One is age. Again, less than 80, they get 1 point. Knee extensor strength more than 3, they get 1 point. Work balance score. These are the 3 items. So in that 0, 1, and 2, depending upon their balance. Now, if you look at that table, if the twist score is listed 0 to 4, and what you see is green is those proportion of people who will start walking at that point. So in the first column, you can see twist score 4. If they have scored 4, they will start walking by 79% chances that they will start walking by 4 weeks. If it is 3, they will start walking by 6 weeks. If it is 2, they start walking by 16 weeks. The chances of is 88% proportion of people. So these tools gives you an idea. So what is important is you to do this tool. So by 72 hours, do the safe score, do the bugle layer anyway to understand severity. Safe scores, PCT, and knee extensor strength and work balance score. With that, you can predict how much recovery is going to happen in upper limb as well as lower. So these are the predictive tools and its predictive accuracy. Now we are looking at what happens if safe score is very less. We know not all places has low potential, so we are trying to see if we shift that with surface EMG and we can still predict it or not. We are still in the process of doing. The last part is the precision rehabilitation. This is basically to tell whether responders and non-responders. So there are certain characteristics. Same treatment, some people will respond, some won't respond. How do you identify that? That is another very important thing, and that's a growing area of research. Some of the aspects that we know is that, for example, locomotor training, patients who have better lower limb control, in Fugal we have scored, if it is there, then their if Fugal score is higher in control motor control part, they achieve walking speed better, and they respond better to the training also. Same thing with extensor power, knee extensor power. Those who have better knee extensor power have better way of increasing endurance. So even if those are the patients, if you want to train them for walking long distances, they are going to be performing better. So in the same group of training, locomotor training, you should know who are the ones that are going to benefit from it. The last part is what we are looking at future. This is where the very interesting things are emerging, where we are using wearables to pick up multiple things. It can be using wearable sensors from accelerometers, it can be different levels. So how rehabilitation is moving towards is to capture what the patient does throughout. And based on that, we are going to learn to individualize the treatment. And using AI algorithms, we'll be able to predict this person does this much of activity more, and especially this is the task that they are interested to do. this is the time of the day they do more. This is what where we have to engage them or modify to improve their tasks. So with that, we are going towards the future. So what we need to right now know is that we should be able to use the available models to make informed decision. Look forward to have capture data to help in developing these models, and but that would be a future. So first step to that is to capturing data. The biggest problem that we have in India is we do not document the data, and that we should change. Data is science, data is value, and data is what will guide future AI. If you feed wrong data, the AI will give you wrong output. So ensure that you collect good data, documentations. Future, we'll be able to create more clearer algorithms to make more precise the application. With that, I end my talk. Thank you. Thanks to BPM for the opportunity. Sorry, 1 minute. Oh, 1 minute.